So it's all about when the good news arrive, what do you do? Do you do one stage, two stages? You do nothing? Periprosthetic joint infection, unfortunately, in the elbow replacement is a lot more common. It can be up to 12%. So when you do a hip or a knee, especially hips, they're very successful. So you cannot compare at all those two joints. What are the factors? There is the elbow joint is very near the skin. There's limited soft tissue coverage. Often the patients we treat have underlying comorbidities. We treat patients that are on medication for rheumatoid arthritis. That alone is enough to increase the infection rate. And there are surgical factors. So when we treat trauma patients, again, they're a lot more susceptible to have an infection because someone was in that joint before us. What's important, I mean, you will investigate as if it is an infection. You'll see most of the criteria are not that good, but what I have there in bold is albumin and iron transferrin level. This will tell you if the patient you have in front of you is someone that has a high risk of infection and complication due to malnutrition. And even though we live in modern societies, a lot of patients we treat, unfortunately, don't eat well. And they have significant problems with their albumin levels. The criteria from the joint infection are not the same as hips and knees. Quite often, you may not have hard signs of infection. Since we treat rheumatoid patients, you might have a high rate CRP anyway, so that's not a clear indication that you have an infection. And often, the way to diagnose you have an infection is you see it while you operate and doing a revision. And in fact, in Aboud's review paper, many patients had low levels of CRP. Only 12 had signs of sepsis and high temperature. And even cultures were negative in 10% of the cases. So this is not an easy diagnosis to make. Therefore, it's a little bit more complicated to treat. What you need to consider is the soft tissue, especially the triceps tendon, which is a big problem when you do revision elbow replacements. The bone stock that you have, the type of implant that is already inside the joint, the neurovascular condition, what is the microorganism, and that's one of the most important things to assess if you're going to choose which one of the three in our algorithm today, and the time from the onset. So the last two things are the ones you need to remember to be able to proceed to the next steps in the algorithm. Yamaguchi which is Morey basically, has a nice classification. So an infection have a stable implant and unstable implant, or there can be significant bone loss, significant enough not to allow for any implantation of anything. So you need big bone grafts to be able to do something. And then when you start to go into papers, you see, if you read the conclusion, it says at least as effective. But if you go and you actually read the paper and see the numbers, I was like that. I have only 2 studies with 7 patients comparing with 87. So that by itself tells you that this is a significantly underpowered study. You don't need to do any further analysis. So the conclusion, at least as effective, is not all that valid. Aboud has a lot more papers in his studies, and even though there is no significant better results with this 2-stage revision, they're both better than, it is better in late infection eradication as a percentage-wise, and it has the best functional score compared to a single-stage revision. So if we go by the algorithm of the British Elbow Society, DAIR has specific indications that you need to follow. If you follow those, you can get a success rate up to 80%. I would be a bit more cautious and towards the 50%. So it's for well-fixed Yamaguchi type 1 implants. This is not for loose implants. It has to be soon after the implantation. Maximum is 3 months. I would say within a month. If you go beyond the month, things become complicated, and the actual duration of infection symptoms is less than 3 weeks. So this has to be an acute infection. This is not something for someone that has bone loss, pus pouring out of the elbow. And what is important is you need to have soft tissue coverage and a sensitivity. So you need to know what kind of organism you're treating. If this is not sensitive to antibiotics and you do just a DAIR, the outcome, again, will be bad. And then the gold standard is a 2-stage revision. These are both for Yamaguchi 1 and 2. The first stage is almost like cancer surgery. So what you need to make sure is you remove all the infected tissue, even if that includes getting rid of the triceps, if you have to. You need to protect as much of tissue as you can, but everything that is dead and infected needs to go. Then you go into a stage of antibiotics. This can be done with a patient at home having a long line and having hospital at home treating them. It's about 6 to 8 weeks. All of this is part of a multidisciplinary team. So what kind of antibiotics, how long for, and what is the interval is decided in the MDT meeting between multiple, or at least more than one orthopedic surgeons with elbow experience. At least a microbiologist, a radiologist, and a nurse that has relevant experience and can help with the further management of the patient while they're not in the hospital. Then you go to the second stage where you do your joint reconstruction with a new implant. After removing the spacer, you need to take new samples. I mean, a lot of studies say this is not necessary. I think it is important to be able to confirm that you have managed to eradicate your initial infection. The spacer needs to be able to maintain the limb length, provide adequate stability, and allow healing of the soft tissue. It needs to provide delivery of localized antibiotics and allow functional elbow range of movement. There are no specific, this is something that I make out of a plate and K-wire. A lot of surgeons do their own spaces for something like this. What's important is to allow movement to avoid stiffness and for the patient to be comfortable during the period, because it will be around 3 months from the time you take it out to the time you put something more inside. And then it's a 1-stage revision. This is, according to BESS, only for after an MDT discussion. You need to discuss whether the patient that you have in front of you is extremely high risk of having 2 procedures, or there are extreme risks for the soft tissue, and then you may decide to go into 1-stage revision, but there is not sufficient evidence in the literature to support a 1-stage revision in elbow surgery. Sometimes, if there's not enough bone stock, you can go into a single bone forearm if there's no place to implant in the ulna. And the complication after an infection, the biggest one is the triceps insufficiency and reinfection. Reinfection rates can be up to 80%, require more surgery. So you are already treating something that has 2 of the worst complications of a total elbow replacement, and you might have a second, a third, or a 4th revision. In some big centers, there are patients with 6 and 7 revisions for an elbow replacement. So overall, the algorithm is you need to somehow establish this is an infection, and this is not easy. Sometimes you operate and you find intraoperatively that this is a possible infection. If it's an acute problem, then with a stable implant, non-bacteria that is low in virulence, you can do a DAIR. If you know the bacteria and it's low virulence and the patient has significant indications to avoid a second procedure, after an MDT discussion, that's extremely important, then you can consider a 1-stage. Otherwise, you go to the 2-stage, which is the gold standard for all of those patients, or you can do an excision arthroplasty. So if someone is really old, really sick, and you don't want to burden them with multiple procedures, again, after discussing with the patient in an MDT, you can just remove everything and allow with a spacer that absorbs with antibiotics time for things to heal. And with this, I'd like to thank you. That's the last picture. It's the same thing from the other side. This is an old part of the city. You're not allowed entrance into that. Thank you.